So greetings, everyone. Welcome to the 187th session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Daniel Fuller. Dr. Daniel has received his BSc degree as well as the Optometry, the Doctor of Optometry degree from the Ohio State University College of Optometry. He has experience working in an hospital-based setting in the US Navy for about 8 years. He then went ahead spending his time for about 17 years in private practice as the owner of the multi-site solo practice, which had emphasis on medical eye and specialty contact lens services. He then began his academic career in 1987 and has the rank of professor and is the chief of the cornea contact lens services and the founding supervisor of the cornea contact lens refractive surgery residency at the Eye Center Southern College of Optometry. He has an experience of lecturing internationally, conducting various workshops, has published numerous peer-reviewed papers, and has done a lot of clinical research and studies as well. He is the diplomate in the Cornea Contact Lens and Refractive Technology section of the American Academy of Optometry, and also the fellow as well as the recent president of the Scleral Lens Education Society. And today he's going to talk to us about one of the very important topics. I would say we all do contact lenses as optometrists and primary eye care professionals. But he's going to take us through how could we probably improve and have specialty soft contact lenses into our practice, which will help our patients in numerous ways. So welcome onto the platform, and let me just leave the screen time to you, sir.
Thank you very much. I appreciate it. And thank you to the organizers again. And it's always a privilege to be able to present to the online optometry learning series. It's really an impressive group and really impressive how many people are willing to participate across the world in these sessions. So it's my distinct pleasure and honor to be here with you today. So what I hope to be able to accomplish is be able to go through some of the things that we do at the college, but also some of the things that I've done in private practice. And when we start talking about getting into specialty soft contact lenses, it's something that is very easy to add to your practice if you're not already providing some of these services, and it's not an expensive thing to add. Now, the challenge is I know that you have different products across the world, so at least conceptually, we'll have similar ways of approaching things, and your access to different products will certainly vary based on where you're located in the world. But conceptually, you should be able to apply these ideas that I'm giving you and things that we present. So what I always like to do when I look at any contact lens candidate is I like to ask myself, well, who are going to benefit from these products specifically, and who is my target audience? You know, which patients are the best candidates for these technologies? So what we do see is that there's a prevalence of contact lens dropout rates of around 30%. Now, the numbers will vary quite a bit. I've seen them as low as 12% and as high as 70%, just depending on how you define what a dropout is. And you also have, certainly contact lens discomfort is very, very common. That's the first bullet point there. The CLD is contact lens discomfort. The contact lens discomfort workshop that was done showed that we have about 30% of our patients that are having complaints and problems with these lenses. And I would tell you that among neophyte wearers, that's even higher. And the reason we don't capture a higher number going forward is that many of the patients, and we see about 74% of those, will be retained during the first year, but we still have a very large dropout rate, particularly within the first 2 months. And if you break them down as to why they're dropping out, 79% of the patients with spherical lens prescriptions are dropping out because of handling issues, which is maybe not too surprising. But I think what it does tell us is that we probably could be doing a lot better job in teaching our patients to handle their lenses, for applying them and removing them, and caring for the lenses going forward. So particularly in the first 2-month periods, you may want to look at your practices and say, are we doing enough to retain these patients and help them develop the skills that they need to have to be successful in the long term? And if we look at toric lens wearers, 73% of those patients are dropping out because of visual complaints. One of the things that we do know is that we don't fit probably as many low astigmats as we should. Patients that have 3/4 of a diopter, a cylinder, many of those patients are being fit in equivalent sphere lenses, which will work for a number of patients, but we know from studies that are out there that about 86% of those patients, when they're offered a toric lens, would prefer the toric lens over the equivalent sphere. So that may be some guidance there, that when you're looking for your candidates, don't overlook the fact that we've got many low power patients in 3/4 cells that probably need to be in an astigmatic correction to be successful over the long term. And then with multifocal patients, it's not too surprising there. Many of them are complaining that their vision is not as clear. And again, what that represents is largely a missed opportunity, that we have patients that were not fitting in multifocal lenses that could be fit in multifocal lenses, that maybe we're putting them into distance only with reading glasses, or maybe we're putting them into monovision. And the numbers on monovision compared to multifocals are pretty comparable. So there's not a lot of difference in success rates. So I would say that it's probably not a big a difference based on the modality that you're fitting, as long as you're doing either monovision or multifocals. But we do know from studies out there that we're not fitting all of the patients that could be fit in the presbyopic correction. And of course, now we've got a number of low dose pilocarpine and other drops, excuse me, that could be ways of kind of extending patients a little bit longer as emerging presbyopes too. So who are our best candidates? Well, we just mentioned some of those. When we look for the contact lens dropouts and we look for contact lens discomfort, I always say it's important to look for the root causes, because if you don't look for those and you don't address the root causes, you're still going to have the problems going forward, because anything that's there without a contact lens on the eye typically is going to be exacerbated or made worse by having a contact lens added to it. Particularly when we talk about things like ocular surface disease, we know that patients' tear films, if they're already very thin and shallow, or maybe of poor quality as well as poor quantity, when we stick a contact lens into the mix, we now have an anterior and a posterior surface of tear film around the contact lens. So that can further destabilize the contact lens and lead to increased amounts of end-of-the-day discomfort symptoms. And some of the signs that you see here are pretty common. So we can see some dryness and desiccation occurring at the superior part of the cornea. And then we see some in the central, we see some inferior. All of these things can represent different scenarios where you may have meibomian gland dysfunction or lag ophthalmos on the inferior staining. And if you have just a very dry eye, and it doesn't have to be a Sjogren's syndrome, it can be a non-Sjogren's aqueous deficiency, you're going to make that worse wearing a contact lens, as we just described. And a good thing to keep in mind is when we talk about regular and irregular corneas and for the shape of the cornea itself and the topography, it's always good to bear in mind that we know from studies that patients like keratoconus patients have much higher rates of dry eye than do the general population. And you can imagine that some of that is related to the fact that the eyelid is being held proud of the surface, and maybe the apex of the cone is getting a tear film distribution, but the base of the cone and the surrounding surfaces may not be getting that typical even distribution of tears as the eyelid would normally close over the surface of the eye. So those are all factors to keep in mind. And also I would throw people in there in that basket like diabetics, any patient that's going to have some compromise in their peripheral nerve system, including the subepithelial nerve plexus. You're going to be short-circuiting that lacrimal functional unit, and so you're not going to be getting the wetting and basal secretion of tears that you normally would have. And then you end up with this kind of spiral where you're producing more and more inflammatory mediators as you move forward in the dry eye patients. And we know with contact lenses, whether it's a corneal GP, a soft lens, or a scleral lens, we see an upregulation in inflammatory mediators. So all these things we know contribute to ocular surface, more and more inflammatory mediators. As on that last bullet point, it's good to stain the cornea to look at these patients, but it's also important to maybe use things like lissamine green and stain the surface of the bulbar conjunctiva as well, because you'd be surprised what you'll find. You can have staining on one or the other. They don't necessarily correlate. So if you have corneal staining, doesn't necessarily mean you're going to have conjunctival staining, but you probably have a higher likelihood that you would find something. But the bottom line is you're only going to find those things you look for. And we stain eyes with corneal GPs and scleral lenses all the time. And it wasn't until I started doing a lot of studies where I was staining soft lens wearers too, that I started to recognize there's a lot of staining going on out there. And not all of it is symptomatic. Some of it's normal. Some of it's just the apoptosis on the cornea. But some of it is a warning sign that you've got a patient that may not tolerate or do well in a contact lens. And you can certainly look at things like tear prism height and maybe get a general idea that way as to whether you produce the right volumes of tears or not. And you can do all these things without having to buy expensive equipment to do meibography and that kind of thing. You can use your transilluminator to do meiboscopy and actually transilluminate the lid and get a look at the meibomian glands morphology as well. So what constitutes a good fit? And this is important, particularly, I think, for our students out there. I know since I am involved with students and residents teaching them that this is something that comes up often is what am I looking for? What constitutes the parameters or observations of a good fit? Well, these are some evidence-based findings. We know that typically lenses, soft lenses that are at least 13.5 millimeters in size or larger are generally going to be more comfortable than smaller diameter lenses. There is a place for small diameter lenses, and there are some manufacturers that will make smaller lenses. I had some 5 and 6 year olds that have microcornea that do well in a 13 millimeter lens or less. So there is a place for some of those, but for the average patient, 13.5 millimeters is about right for a spherical lens. When you're talking about toric lenses, obviously most of those are going to be larger because we're trying to add the prism ballasting and we're trying to increase the sagittal depth of the lens to help tighten the fit up a little bit so we get a little less rotation in the lens. So you may see with your torics, you've already noticed that those run larger diameters. So all these things are good to bear in mind as you're starting to think about how you might design a custom soft lens. And we know that it's important for that reason to also be looking at the HVID or the horizontal visible iris diameter, white to white, or corneal diameters. There's a number of different terms for these things, and we'll talk about that in a little bit too. But centration and movement, how much movement is enough? With the first generation of soft lens materials back when I was starting out, the DKs were pretty unimpressive, maybe around 8 to 10, 12. Then we needed certainly a lot more movement, and the soft lenses had to exchange roughly about, say something like 1% of the tear volume on every blink is what they were exchanging. In contrast with a corneal GP that exchanges something like 20% of the volume behind the lens on every blink. So certainly with soft lenses, we don't get as much movement. And when you had a low DK lens back in those days, it was probably more common to fit a little bit looser. Certainly we were always teaching fit looser fits for extended wear than you do for daily wear. But what it turns out from a standpoint of just comfort alone, anything that moves 0.3 millimeters or less generally does not impact the comfort until you end up with things like hypoxia. But we think the sweet spot is probably something in the order of about a 0.5 millimeter to a millimeter being about the right place to be for the amount of movement of a lens. So obviously thicker lenses, something like you may have with an aphakic, you may get greater movement than you would with something that is a -3 type lens. What other things go to the attributes of an optimal fit? And again, these are evidence-based things that come out of the contact lens discomfort workshop. So there is study data that's been collated for you if you want to wade through that rather long document. But we do find that edge profile can be an often overlooked attribute to a lens. What I did here is I took a couple different lenses and cut them in half with a razor blade and then took a picture of them through a stereo microscope so that we could actually see the edge profiles. So it turns out that chisel and blunt edges, and that would be that upper left picture there where it's kind of rounded over. If you can, I don't know if you see my arrow here, but moving the cursor, those tend to be less comfortable than these knife edges that we see that are more characteristic of lens designs like the J&J Vision products. They have what they call their infinity edge, and they will tell you, and they like to brag, that it's never been beaten in more than 26 clinical trials at clinicaltrials.gov, which is a site run by the FDA for monitoring clinical trials in the US. So the knife edges actually tend to be more comfortable. But interestingly enough, if you look at your patients that wear AccuView products, and this is what you have down below, whoops, let's go back. You can see where that yellow arrow is pointing to, that when I stain the cornea, you actually get some arcuate staining that occurs with the knife edge, where you can imagine that that edge is making greater direct contact with the bulbar conjunctiva and maybe increasing the apoptosis a little bit in those areas. But that from the edge profile that tends to be most preferred by patients. So you can see that there's not a one-to-one correlation or connection between the amount of staining you see and whether the patient's comfortable or not. Well, we've already known that from, I think, the DEWS workshops, that signs and symptoms only correlate about 50% of the time. But it's interesting, if you're not staining the eyes, you may be left wondering the first time you do whether this is a normal finding or not. So I would tell you that the more you stain and the more you do these kind of things on soft lenses, the more you get to appreciate what's bothering that patient as an individual. But I thought that was a very interesting finding, that correlation is the same when we talk about soft lenses as it is when we talk about dry eye. We also know that prism ballasting can affect the comfort too, that patients are sensitive to the differences in thickness of lens profile as you go across the cord length. So obviously the prism ballasting is ideally sitting around 6 o'clock, and they'll put about typically 1.5 prism diopters, sometimes less, in depending on the lens design, to help the lens stop from rotating. But patients can be sensitive to that. You always have a handful of patients that are very sensitive to small things. We know from, I think it was one of the two largest manufacturers, that when they came out, they started putting laser marks on their lenses. And for whatever reason, they changed how they did that. And patients were actually sensing that laser mark. And so they had to go back and recalibrate things so it was not going as deeply. And you wouldn't think things like a laser mark would be that noticeable to a patient, but it just goes to show you that some of our patients are very sensitive, others are not so sensitive and discriminating. We don't have as much data to look at comparisons of multifocal comfort to spherical soft lenses, but they do seem to be comparable, and it probably has a lot more to do with the geometry of the lens and being rotationally more symmetric. Certainly, if you had a toric multifocal, you might expect that those are a little bit less comfortable. So when you're starting out and you're trying to fit a patient, I always like to say it's like Google Maps. I can find my way from the college to my house out in the suburbs in Memphis here, going at least 3 different ways. But I always want to start out with the end in mind. I know where I am now and I know where I want to end up, and then I can map out my trip along the way based on what's needed for that patient. So when we're talking about specialty lens fits, we always have to kind of bear 2 things in mind. Are we going to be undertaking this fit to actually restore function or to preserve physiology? And you could add a 3rd one on there, maybe a 4th one too, that the 3rd one would be, are we trying to improve cosmesis? And that's all. And the 4th one would be, are we doing some combination of those factors? So it's always good to kind of start out and plan your work so that you know what you're doing. And it also helps serve as a guidepost that when you're talking to your patients and you're trying to understand what their expectations are, I always tell my patients that if your expectations are way up here and the ability for the product to deliver is down here, that gap in between represents both of our disappointment. So what we always try to do is close that gap and get the patient expectations to match up with what the technology can actually deliver for them. Now, we're very privileged at the college because we have these crazy budgets where I can get most of anything that's new and hot out on the market for in the way of instrumentation so that we can expose our students to all of these different technologies. But as a private practitioner, you know as well as I do that you're always trying to do a return on your investment analysis and decide which instruments will do the most for me at the lowest price, because many of the tests that we do are not separately billable procedures. And what I've always done throughout my career, including my 17 years in private practice, was to make a decision based on what was in the best interest of my patients. And I worried about the money as a secondary issue. And if that meant that I do tests for patients for free and I'm absorbing the cost, but it ends up solving the patient's problem, well, then I think that's kind of an intangible or a cost that I'm willing to bear. And maybe I adjust my fees across the board for my services to offset that. But many of you may be practicing in countries where you have a socialized medicine where that may or may not be as big an issue for you, or you may be in large institutional settings where you have a well-funded service and you're able to access this equipment. But nonetheless, I just go over these things to let you know that they're out there. And do you absolutely need to have all of these things to be successful? The answer is no. We started out doing things as simple as assessing corneal topography by putting a flat-fitting corneal GP on the lens. Now, you're not going to get the precise data that you get out of a tomographer, but you're going to get the information about where the peak is located and approximate differences between the apex and the base of a cone and that kind of thing. So there are some very low-tech ways to get that information as well. But topography gives you curvature data for the most part. They typically are Placido's disc topographers, and those are going to give you things reference to the visual axis of the patient and the instrument. Tomographers give you true height and elevation data, so that's very valuable. And scleral profilometry is the latest thing. That gives us information that goes out beyond the cornea onto the sclera, which helps when you're fitting larger diameter lenses for sure. And then, of course, there's all kinds of manual testing that you can do. There are probably still plenty of manual keratometers out there in offices, and there's nothing wrong with that. It's just that you're measuring a smaller field of view, maybe 3.5 millimeters. And many of your autorefractors and autokeratometer combinations will measure something along those same lines, whereas you contrast that with a scleral profilometer that's maybe doing 18 to 20 millimeters or more. Now, how do we interpret this information? Well, I also look at factors like pupil size. And I look at them in scotopic and photopic illumination. As we're dealing with higher power lenses and things like that, if we're dealing with toric lenses where you have an elliptical optic zone because you have a major and a minor axis, pupil size becomes an issue. If you start to have pupils that dilate outside the optic zone diameters, then you're going to have patients complaining of glare and flare and halos and night vision problems. So I like to go into it knowing that my blue-eyed young patients have bigger pupils than my presbyopic 60, 70-year-old patients where it may be less of a factor. But I also want to know something about lens decentration. We'll talk more about that as well. So age can be a predictor. You know that we have some lenses out there from Johnson & Johnson Vision that consider pupil size and age as they formulate the ad powers and the size of the ad zone on their multifocal lenses. So they've taken it to another level to do that for us. Refractive error in and of itself is not all that's significant, but we know that in pre-presbyopes that myopes will have bigger pupils than a hyperope will that may be still accommodating through whatever latent hyperopia is there as well. So we kind of know that our pupils also, like I said, start out small. If you look at an infant, the pupils are very, very small. And then as you get through childhood and adolescence, they kind of peak in size. And then as you get into the presbyopic years, the pupils are once again getting smaller to kind of build in that pinhole camera effect and offset some of the loss of accommodation that we have. This can all be a significant impact on things like multifocal fittings, particularly. We know that center near lenses have smaller ad power zones and concentrate that ad power into a smaller zone, say something on the order of 1.8 millimeters to perhaps 2 millimeters, where distance-centered lenses may be more like 2 to 2.2 or even higher in terms of the size of that central distance portion. So we know that that can be a factor in terms of how things center or decenter and whether that's going to cause a problem over the pupil. We know that the corneal cap of the eye is decentered, and that gives rise to things like the angle kappa, angle alphas that we're aware of. We certainly take that into account when you're doing IOLs, and it's something that we're thinking increasingly about as we're doing lenses now, particularly like scleral lenses, where we can get decentered optics to help align those optics better to improve patient performance. And even with the aberration controlled lenses that we have out there now, that centration is important to consider when mapping out the optics. Unusual diameters, it's good to bear in mind what the norms are. So we know that typically anything under an 11 millimeter corneal diameter is going to be a microcornea. Anything over 13 is going to be considered a megalocornea diameter. And oftentimes this is accompanied by some underlying pathology, but not always. Sometimes we just encounter those, what I would call a freak of nature that is out there, because we do have a kind of a bell-shaped curve. And then every once in a while, you're going to consider that you're going to run into an outlier either on the small end or on the large end. And if you get accustomed to looking at your patients as they sit in the chair and you're making eye contact with them and you're not having to turn your back to the patient as you're typing everything into the computer, transcribing things these days, it's always good to take a moment and at least just kind of visually inspect your patient, or as you're under the slit lamp, maybe take a look at them under the slit lamp. And, you know, many of the devices we have these days in topographers and keratometer or tomographers, and also in autorefractive autokeratometers, actually capture this data for you, and we'll give it to you. If not, then we've got these horizontal visible iris diameter rulers you can get from various manufacturers at no cost to help you gauge the size of the cornea. And all of that's important when we start talking about sagittal depth. So for further interpretation, you know, again, we talk about a number of factors. Here are two eyes that have very different underlying pathologies. You have a keratoconus patient, which is a highly prolate shape eye. The normal shape of a cornea is prolate. It's flatter in the periphery and steeper in the center, and a keratoconic eye certainly is an exaggeration of that. And then we have oblate eyes. These are eyes that have had things like refractive surgeries done, LASIK, PRK, radiokeratometry, those kind of things. And you can see the difference that the shape matters perhaps more sometimes than the actual curvature of the eye. The one that's below with the penetrating keratoplasty is a less extreme corneal shape, but it may be more difficult to fit because you're dealing with a very steep peripheral curve, and most of the lenses that we have designed out there are designed for more of a prolate shape eye, not an oblate shape eye. So it's important that you recognize that, and that will guide you into whether or not you need to be considering reverse geometry lenses or not. So here you heard me kind of foreshadowing and talking about the importance of the sag and the base curve. It actually turns out that base curve has a lot less to do with the fit in a soft lens in particular than the sagittal depth does. And so the way to interpret that, as you can see with this very busy equation to the left, is having sagittal depth as a function of the radius of curvature of the eye, the chord lengths, and what P is a shape factor that's a value you can get off of many of the topographers these days. But what it basically tells us is it tells us that if we look at the horizontal visible iris diameter, the larger those are, the deeper the sag of the eye. And so you can imagine that as we have, say, both the corneal shape and the cross-section on the tomography, and we have a scleral lens to the right of that, that if you have let's say the black line here on the scleral lens representing a small corneal diameter, you can see that the sagittal depth is going to be less. When you have a larger diameter cornea, let's say that yellow line, the sagittal depth is going to be much greater for that larger diameter eye cornea than it is for the smaller diameter cornea, even though the curvature has remained exactly the same. So that really stresses the importance of looking at the horizontal visible iris diameter and recognizing that if you have a -3 patient, but they've got a 12.7 millimeter cornea or 13 millimeter cornea, that same standard nominal base curve that you might reach for in your fitting set is not going to work on that patient. So you may have to go with a lens that has a correspondingly larger diameter. Maybe you go to a 15 millimeter diameter lens with an 8.3 base curve, and that way you get a larger sagittal depth. It'll tighten the fit. It won't be loose. The patient won't be complaining of blur and discomfort then. So that's how we use sagittal depth to make these predictions. If you really want to get into it, the folks at Pacific University have published some data that looked at sagittal depths for toric lenses, for spherical lenses, and daily lenses and monthly lenses. And you can randomly change lenses and eventually come upon a diameter and base curve combination that's going to work. But they've taken some of the guesswork out of it for us now, where they have some scales that are out in some of the literature that's been published that actually would be helpful little guides where you look at them, and they've taken the guesswork out of it for us by actually calculating these values. And so you can precisely look at product A and move to product B or C or D, knowing that you're getting a deeper sagittal depth. There's no way to really know that looking at the base curve radius, because like we said, the base curve radius is actually a minor contributor to how tight the fit is going to be compared to the overall sagittal depth of the lens. So it's that base curve plus the diameter that matter, that gives us the sag and not just the base curve. And so that's, if you want to do a little research, you can find the article on PubMed, or you can email me and I can probably find it for you and send you a link as well. But these are great ways to kind of helping yourself in clinical practice, so you're saving chair time. Other factors we can look at, the shape descriptors. One is we talk about is eccentricity. The normal eccentricity of the eye is around a 0.5. You'll see these various values reported out. Here you see for a med mount topographer, it's being reported out on the right-hand side. 0 is an ellipse, or excuse me, 0 is a circle, 1 is an ellipse, but it doesn't tell you anything more than that kind of data, or eccentricity data, because you still then don't know about the shape. Is it prolate or oblate? When you have eccentricity values that are getting greater than 0.8, you've got a high likelihood of having keratoconus, and the normals are going to fall there somewhere in that range that you see there. P-value, that's the shape value. And here you can derive that if you know the eccentricity values. I've given you a little formula there. Again, an average value there is a negative 0.75. And here with the p-value, the advantage is you can tell whether it's a prolate or an oblate value looking at it. So that's where the p-value may be more useful to you than eccentricity, and why you see the p-value plugged into that equation I gave you for sagittal depth. Asphericity too, the rate of change is important, or what they call the conic constant. Here you can see you can get some shape value out of that as well, and also a value that can be derived if you know the shape value or eccentricity values. And you can see a normal value is somewhere in that negative 0.2 to negative 0.3 range. Diameter, again, just stressing the point I've already made, that 62% of the sag can be attributed to the diameter of the lens, where only 33% goes to the base curve. Fitting guides are based on an average corneal diameter, and a change of the HVID by a 0.5 millimeter will give you roughly about a 2.5 diopter change in the effective keratometry value. Using the p-values of 0.8 or an eighth of a value here, 0.12, that equals about a diopter change, which would allow you to further refine the estimates of your effective K values too. So if you know these values of what norms and norms are not, you can use that equation to kind of plug in these rules of thumb to get a estimate of whether you've got an effective K value that's going to be steeper or flatter because of the increase in sag or decrease in sag. So here I give you a couple sample problems to work through. I won't belabor these for you, but if we take those normative values and kind of a more or less normal eye shape and keratometry value, you can see that it's going to actually fit a little bit steeper than what you might have predicted it would fit if you just went on K values alone. So when you look at those base curve values on the vials of your soft lenses or on the blister packs, you can recognize that there's going to be this mismatch because it doesn't take into account these other things like the HVID or shape values. And here we go to another extreme where if you have a very large corneal diameter of 12.3, you're actually increasing the effective K value. And so you're going to have a lens that fits quite a bit steeper, more than 2.5 diopters steeper. And if you have a change in shape values, then you can do the math here and work it through and see that you can actually end up quite a bit steeper than the K value alone would tell you in that. And we say K values, usually we're talking about within the central 8 millimeters of a cornea. So just some ways to kind of do the math, play with that at home, and get some sense or idea of, again, how those relationships affect your fits. Profilometry, the sclera is typically higher and flatter nasally. We know this from all of our work now in the scleral lens study group with Greg Denaire and others, that about roughly 62% of the time or so, you're going to have an irregularly shaped sclera. Well, just as it affects our scleral lenses and pushes them off typically to the inferior temporal side, look carefully at your soft lenses, and you will notice that most of your soft lenses, because they're in that 14.0 or 14.2 diameter for a spherical lens, are going to also decenter just slightly off to the temporal side. Now, for most people, most of the time, that's probably not an issue. But if you have somebody that has a very large angle kappa and you're trying to fit them in a multifocal lens, it can be a deal breaker. And these are patients that come in that don't see well at distance or near, and your over refraction doesn't seem to improve either of those. Well, there's probably a good bet that you've got a lens that's decentered. and you can go and take a look at it. Either that or they've got a very large angle kappa. But you can find these things actually by doing over topography on a soft lens. And we do that with our multifocal lenses to see if it lines up with the outline of the pupil below with the lens on, because we can actually see those multifocal zones with the topography. And if they don't align with the visual axis of the patient, then we know that that's an explanation for why they're not doing well. So that can help you a lot with troubleshooting. And so here's making the point a little bit greater, maybe in a graphic form. So up above, you see a IOL lens that's decentering, and they'll purposefully do this in the OR, try to get it into the capsular bag and get it positioned over that visual axis, which may be very different than the geometric axis of the eye. So they do take into account angle kappa and angle alpha as they're trying to center these lenses, and particularly with some of these new surgical planning platforms that allow you to visualize that in a heads-up display. Your surgeons are looking for this as well. And you can see in the soft lens there, what I've done is I've kind of given you one small pupil in yellow and one larger pupil in the red, and I've superimposed that on top of the optics of a aphakic lens here, where you can see the optic zone outline, and then you can see kind of a plano carrier around it. And you can imagine what impact that's going to have on the patient, particularly in their night vision and also in their visual performance. As the increase in power goes up, you know that Prentice's rule is going to induce a lot more prismatic distortion as well. So all these things conspire against you to produce the higher order aberrations and defocus that end up decreasing your patient's performance. Other things to think about, again, we just mentioned high refractive errors are a bigger problem than lower refractive errors, and they come in a variety of flavors, whether they're high myopes or aphakes or something in between, and high astigmats. And the higher the astigmatic correction, remember, the more elliptical your optic zone is going to be on the lens. All soft lenses are made these days with back surface torics to help them stabilize by locking into the corneal curvatures. That assumes you have corneal curvatures. We know with against the rule astigmats, you may have very little corneal toricity, but still have significant amounts of astigmatism. And so their prism ballast lenses, that back surface toricity may not be helping you much. You may have to go with other stabilization designs that use a lid lens interaction in a different way, or you may have to tighten your fit up a little bit by using a lens with a deeper sag on it that gives you a little bit better alignment with the sag of the patient's eye. So here's a case that I had. This is that 5-year-old girl, in fact, that I was telling you about, that is a microcornea patient. She's an aphake. You can see that she's got a surgical pupil too that's now decentered. So she had a number of things going on there, but it's good to be able to visualize these things. And I would just call your attention to the black and white image off to the right side there as being probably the easiest one to look at. And there I've mapped out for you what the HVID is, and it's around 9.8 millimeters. So you can see she's got a very tiny cornea with 11.5, 11.7 being kind of the norm. You can see she's well below it, and certainly well below the 11 millimeter threshold for being considered a microcornea. If you move over then to the K values and you look at the SIM-Ks, you can see she's got Ks that are extremely steep in both eyes. And in fact, we did have more trouble getting a lens to fit in that left eye, but I was able with a custom soft lens to design a lens that was smaller in diameter and steep enough to give her an excellent fit. This was something that I could not do with the SilSoft lens that's out there, where you really have a limited range of parameters, if you can even find it anymore, because it's an orphan product. But there are still manufacturers that will make custom-made soft lenses and a variety of powers, base curves, and diameters. And so you can call your labs and make up a lens to do that. In this case, we did one from XL Contacts with the flex lens, and you can see that normally we associate very steep eyes with being myopic. Here, because of her microcornea, it was very steep, but she was an aphakic, so we had to have a very steep plus lens. And you can see the base curves there that I came up with were 7.70, where a normal base curve for, say, an AccuView lens might be in the 8.4 or 8.3 range, and something in a 14.0 diameter or even a 14.2 diameter. Here you can see that we came up with something that's quite a bit different than that we're doing something in an 11.3 diameter, and then I had to go a little bit larger diameter with the same base curve in the left eye to get that deeper sagittal depth that I needed because the corneal curvatures were so steep. And we're actually able, with a pair of reading glasses over top, to get this young lady down to 20/30. And so I've seen her since she was 5. She's now gone off to college, and I saw her just this year as she was headed off to college. And it's very gratifying to see that she's done so well with a high decay lens that, it's a little bit different calculus when you're talking about fitting infants and fitting children who are going to live another 70 years, God willing. After you see them, you don't want to induce neovascularization and limbal stem cell deficiencies and problems in a child because they're going to have a whole lifetime to live with that. It's bad enough when you do that to a 60 or 70-year-old, but certainly it's even more important when you're dealing with your young patients. But a very good outcome for this patient. And again, something that you can do with your practice, working with your labs without necessarily having more than a couple different lenses around. What I do is when I have one that doesn't work out, I just keep those lenses and have created a little mini trial set for myself. And the investment is just my cost and the lens. So probably for about $50 or $60 American, I've developed a 3 or 4 lens set, which is all I need for these specialty corneas that I'm doing. Here's another example of a multifocal toric. This actually happened to be a member that was of our board of trustees at the college who's an avid golfer. You can see there that he's got rather steep Ks and that he was having trouble with an off-the-shelf fit of lenses. When you look at the amount of corneal toricity and you look at the amount of refractive toricity, you have a bit of a disagreement there. And so he was not seeing very well because of the residual astigmatism. And yet I was able, with a custom multifocal toric that was made to order, I was able to finesse his fit to get him to 2015. And he was just ecstatic about that with a multifocal toric. And he also had a fairly large iris diameter, corneal diameter, as pupils were pretty typical. But it gives you an example of something you can do to go beyond just a stock toric lens. This particular company that I was working with also has the ability to decenter the optics, and that's something that we can always do on some of our hard-to-fit multifocal patients that are just seemingly struggling no matter what lens brand you put them in. Having the ability to decenter those optics can be a real blessing for them. And again, something you can do without a trial lens. You order the lenses empirically, and then that first lens effectively becomes your trial lens, and then you talk to the consultant. And usually within 2 lens orders or so, you're going to get something that's much better than anything that they could have off the shelf. And I love that when they come in and they tell you that, and they challenge you, and they sit there and you ask them about their wearing experience, and they say, well, I've been to see 5 or 6 doctors. They've never been able to fit me. So what are you going to do? And so it's kind of like challenge accepted. They've thrown the gauntlet down and given us an opportunity to help them. And so here we just apply the basic optics and concepts we know about their anatomy and their biometry, take a little bit more time doing it. And I tell you, if you're talking about something that will build your practice, you fix 2 or 3 patients like this, and they will tell all their friends, and you will start getting all of these kind of patients coming to you. And they're not always very difficult patients to fit. It's their family members and the people that you're trying to get in that are the easy fits too. But certainly other patients that have problems talk about it with their peers. And it's great to build a specialty lens practice with that. Helped me a lot in private practice. So for him, again, going through, he needed a presbyopic correction and a toric. And we know that most of those are made to order. We have with the B&L Ultra Toric out there, if you have access to that in your country, that we have trial sets for those, which has helped a lot with these kind of patients. But there's still a very good number of patients that are outliers on the bell-shaped curve that won't fit into those, and that this individual is one of them. In many cases, their astigmatic correction in the stock parameters, particularly in dailies, may not go above a -175, or if they do, they may go 225 or so. But there's still a number of patients that may have higher options that are needed. We also know that the vast majority of soft lens options out there are near center designs, with the exception of some of the Cooper Vision products. But on a made-to-order lens, you can have either a distance center or near center. These are also great opportunities to maybe think about doing a bitoric multifocal and doing that in an aspheric or simultaneous view lens design. Those work great. I've done that on a number of patients and had great success. I did one of those, in fact, just on Friday. She's been wearing the lenses now for about 3 years and just ecstatic about them. But this Board of Trustees member that was a golfer I was telling you about, we worked with a company called Speciality, and they're able to decenter optics for you as well. And the patient was very happy. And you can do it as either a decenter or end center. You can change the zone size. They actually have an arc length calculator, if you've not seen it on their website, where you can actually see what you're doing by adjusting the vision, by giving you a simulated eye chart, and you can see the amount of focus or defocus that occurs in a very graphic way. I always tell patients and students that, fitting multifocal lenses is a lot like riding a teeter-totter. I can make the one end go up, or I can make the other end go down on a fulcrum, but I can't make both sides go up at the same time. And the same thing is true when you're fitting multifocal lenses. I can weight the vision to improve your near, I can weight it to improve your distance, but I can't improve distance and near at the same time. So we end up making the best compromise for that individual patient. And the more flexibility you have in being able to do that, the better you are able to fix these things. So let me move along into some of the higher prescriptions here. Certainly, when we deal with refractive errors, you know that we're seeing a myopia epidemic. That means we're going to be seeing more degenerative myopes out there. Having simultaneous view center lenses like MiSight can be very helpful for heading that out for myopia management. So you might put that in your basket of options that are out there. There are some other options around the world. Natural View is another one that makes an extended depth of focus one. You can also put prism into soft lenses, and a lot of people don't think of that. We do think of it when we're doing toric lenses, but you can also, in a spherical design, put a prismatic correction in too. And I'm going to skip past this degenerative myope because I think you appreciate the need to be doing custom lenses for some of these patients where they exceed what's available in the stock parameters, or you want something that has a higher amount of toricity than what you can get in stock parameters. But let me jump forward a little bit here. Okay, here's the one I wanted to get to. This is one of my spherical lens patients. She was referred to me by our folks in vision therapy. She had a vertical imbalance, but she also had traumatic or acquired brain injury, I should say, and was having vertigo and some imbalance problems. And her current lenses that you can see there, they were high minus. So she was getting a little bit of a vertical imbalance probably from that, but not a whole lot. Prentice's rule, that's not going to make a big difference. So what we ended up measuring was that she was a 2XO with a 1 left hyper. And what we were able to do was go ahead through and put that into a lens, easily you can put a prism diopter half, even up to 2, seldom more than 3 prism diopters. And now even with some of the soft lens designs out there, you can start putting in lateral prism. And certainly if you're doing scleral lenses, you can add lateral prism to some of those. So it's a way of helping these patients that have these vertical imbalances or, phoric imbalances to help resolve the problem. And you can see here, we put a diopter and a half in there. Happy patient, she resolved her vertigo, and that's a patient that's not going to go to any other doctor. They're only going to be coming to your practice because you solved the problem that nobody else could do it. Here's an example of prolate versus oblate eyes and where that comes into play. And here with this NIDEC unit, Marco distributes it. You can see we get all kinds of corneal asphericity and eccentricity values. I use that information. Also get measurements of what their white to white corneal diameter is there. Here you can see it's a little on the larger size, but you can see you've got a very large asymmetry here across the hemichords on this cone patient, and that makes it very difficult to fit. But be aware that there are soft lens designs out there also for keratoconus and post-surgical patients that need a reverse geometry lens. Here you can see the differences. And when we talk about masking astigmatism or masking refractive errors in soft lenses, we're not talking about the same kind of tear lens effect that we get with a corneal GP lens. Here you can see a biofinity lens on the right, and you can see a lens that's called a Kerasoft IC Thin, approximately the same values for the refractive error within a quarter diopter, but very, very different center thicknesses. And here you can see that the Specialty lens has a center thickness that's over 3 times, and they can go even 5 or 6 times the normal thickness of a lens, where it may be, in this case, maybe a 0.15 millimeter thickness. And what you're getting there is by having a thicker lens, it's simulating a higher modulus. And we know that when we put any soft lens on the eye, it's going to drape across the corneal shape, and it's going to induce higher order aberrations. Well, the less draping you have, the fewer higher order aberrations, and the more masking you're going to get of those aberrations. So the masking effect that you get in a soft lens that's really thick like this is just due to that and not due to a tear lens effect. So it's important to understand optically the distinctions there. So the advantages here in doing a soft lens is I can do plus or minus 20 with this particular design. I can do any axis around the clock in 1 degree increments and up to a 12 diopter cylinder. Now the disadvantage is obviously thicker lens means lower oxygen transmission, and so that's a concern. You get higher order aberrations in soft lenses because of the draping, even in the very thick ones that you wouldn't get in a scleral lens or in a hybrid lens or a corneal GP. And these are lenses that typically we're going to replace every 6 months. So you may have to think more about protein deposition and buildup or lipid deposits. And so you may have to alter their care regimen as well. So, but these are great for patients that have a relatively asymmetric presentation of keratoconus, or maybe they've had surgery on just one eye and they're doing fine with a stock lens in one eye, but they need something more for the other eye, but they don't want to go to the comfort differences of a corneal GP or even a hybrid. And here they make a great bridge or transition for those patients where you can keep them in soft lenses a little bit longer. You can measure that draping again by doing topography over top of the lens as well. And these are all, again, back surface torics as well. So here's a keratoconus patient that we looked at wearing a Biofinity XR, and we're able to get a very decent set of visual outcomes to 2025. But because of the draping, the patient wasn't really happy. And so we went with this thicker lens. We actually got a line better of acuity in the right eye than we did in the left eye. And if you'll notice, we actually were able to do it with a lower amount of astigmatic correction as well. Because of that masking effect of the higher order aberrations, they weren't getting as much astigmatic aberration. So which one's better? Well, I think the ones with lower aberrations, all things being equal otherwise, even though we're looking at Snellen acuity, we know that visual subjective experience is a lot more than a recognition acuity. We know that these aberrations do matter, particularly in highly irregular corneas. And so for this patient, they were much happier in the Kerasoft lens. I won't belabor this, but it basically is a way of demonstrating where the higher order aberrations are coming from on the cornea or internally. So if you have the technology, you can get more information. There are tables of norms that go with higher order aberrations. They're going to vary dramatically based on ages, pupil size, tear film stability, and so on. So it's really not all that important. I think that you know these values. If you're really keen on it, you can look them up, and there are tables you can use, particularly for research. But I think just conceptually, if you'll just remember those things I just talked to you about, as far as the amount of draping in a soft lens creating more aberrations, that explains why corneal GPs are preferred for keratoconus patients over a soft lens, and why patients get to a point where they're complaining of ghost images and blur, that even though their recognition acuity may be not that bad, they're still very symptomatic. And we can address those symptoms with either a thicker soft lens or going to a rigid lens design for that reason. These again just kind of go through all of those aberrations and the things that affect them. Like I mentioned, tear film stability, pupil size, accommodation, and refractive error. And we talk about the impact on higher order aberrations, but also think about high and low contrast sensitivity functions affecting the patient too, and how those are affected under mesopic and photopic conditions as the pupils dilate. So toric versus spherical lenses, it does matter. And they're going to be affected because of the differences in the optic zone being either spherical or being toric. And we talked about soft lenses working better when they're thicker. And when we talk about the spherical aberration, there minus soft lenses reduce that. You get better centration of the optics than you do with some corneal GP lenses on some occasions where you're having trouble getting the lens to center well. So this is where either having hybrid lenses where you have that soft skirt, or scleral lenses, or just going with a thicker soft lens can help too. You get less draping and less rotation. So all of those are some of the optics behind why these things work a little better. Let's quickly run through some tints and prosthetic tints here. This is a colleague of mine where I put basically a X-chrome type lens, or a red centered lens. She's chief of the low vision service. She has a number of rod cone dystrophies that come through, achromatopsias, things like that. Many of these patients, albinos, people like that, can benefit from having a lens that controls that light and reduces their photosensitivity and the veiling glare that they get by having a red centered lens here in the right eye. And the left eye, I've got another lens on her that basically is a prosthetic tint that you can see her natural iris color is sort of a green color. Here I've turned it brown. The brown eyes are very easy to work with in getting a lens to center, either with or without a clear pupil. Here you can see a number of patients I've had. I've got a couple here, both of which had band keratopathies. You can see the one had the band keratopathy removed and it's grown back. That's in the upper left-hand corner here. When you have retinal detachments and they do silicone oil, it's very common to develop a band keratopathy afterwards because of the silicone oil. Here I was able to fit her with a prosthetic tint, and then all I did was order it with a black pupil, and you can see the comparison to how she looked below on the bottom to how she looks when it's fully corrected with the prosthetic tint. And you can see you can do it just as easily on patients that have green colored eyes and blue eyes as you do and the ones that have darker colored eyes. And this one that I did in the middle here, this one is really a neat technology where you can actually layer up iris patterns, so you can mimic the little brown band around the edge of the cornea, around the iris that she has in her natural eye, and some of the flecks of color that are in the pupil and around the center of the pupil. So what we literally did is just stack those lenses up, and we remembered the order in which we stacked them, and then we ordered that from the company, giving a really great cosmetic outcome for this patient. You can also do this with a lens that has power, so you can do spheres and toric powers in these as well. But in this case, it was a non-seeing eye in all three of these examples, and we were able to just do it for cosmetics. Sometimes you have an eye that turns out and is so exotropic that you can't really get a good soft lens fit. And there are some patients that do very well with hand-painted scleral lens fits. And that's what we're seeing here on the patient, is we did a hand-painted scleral lens for a guy that has a practice down in Florida and does these beautiful hand-painted designs like this. And these patients are just absolutely ecstatic. I think you can tell that this is probably a younger patient, and that their self-perception, their awareness, their whether they're outward going in the world or whether they're introverted in the world is oftentimes affected by this. And she was just thrilled. Here's a patient with ocular surface disease, 99-year-old patient. She developed an ulcer after a cataract surgery. She was more together at 99 than I was at 60 at the time. And so we did something for her, and I said, well, I would love to do a scleral lens for you. And she just did not have the dexterity to do it because of some rheumatoid arthritis problems. So what I did for her was a bandage contact lens. And so we would have her in that until the neurotrophic keratitis was addressed, because she had these recurrent episodes like that. And we were able to get them to heal up. And the nurses in the nursing home were able to take care of that for her and replace the lens. And then I'd come back and check her periodically, maybe once a week or so, and worked great for her. So lenses for ocular surface disease, bandage contact lenses, we often forget about, with or without amniotic membranes. In this case, I did it with an amniotic membrane, can really help change the quality of these patients' lives. And then lastly, just to kind of close the loop on things here, since I've had you for a while, the first drug-eluting contact lens became available in Canada and in the US this year. So these are for patients with allergies. It's built on the Edafilcon A AccuView Moist daily disposable lenses. And they have the ketotifen in there that is a mast cell stabilizer and H1 histamine blocker. And it also inhibits inflammatory cell migration. It's preservative free, and they are daily disposable, so they're single use. Patient uses those. So if you have, and they do have powers in them, so your patients that want to continue to wear lenses through allergy season that may not be doing well with topical drops and they still are symptomatic, well, this may be a better option for them. So just recognize that our toolbox of drug-eluting contact lenses is only going to continue to grow, and there are going to be very specific indications for them, but they can be problem solvers for patients that have failed in all other options. So with that, we'll let you catch your breath, and just remember that, in many cases, trial sets are not necessary, or if they are, they're very small sets. The investments are minimal in doing these, and you change people's lives. These are patients that are just ecstatic and happy. They refer a lot of patients to you. And so you can really get into specialty lens fitting in a very easy way. And you've got labs where you can upload these images and be able to take pictures with your cell phones. Just remember those protected personal information things. There are laws in the US about having any identifying information on a patient accompanying an image if you're not using a secure web transmittal process. But certainly the low-hanging fruit, high refractive errors, custom torics, those are things we can all do in our practices without having to move into bitoric GP lenses and things you may be less familiar with or less comfortable with, but they certainly do change lives. And these patients are already in your practice. You don't have to go out and market to bring them in. They will feed on each other, telling each other that you offer these services. Certainly those of you in institutional settings and ophthalmologists in your areas, once they find out you do these things, and if you send them a little brochure that you're offering these services, your practice will grow faster than you can imagine fitting these patients. The more it grows, the more lucrative it is. You can afford some of these more sophisticated technologies. But these days, there are so many devices out there that do multiple tests for you. It's getting more and more affordable to add those to your practice. And the return on the investment for these types of fits can be substantial. And the consultation with your labs, I can't stress that enough. Your lab people can help you tremendously in troubleshooting problems like this. And I've got references there for all of these things where you can kind of look them up if you want. But that's all I've got. So from Memphis, Tennessee, on a beautiful Sunday morning as the sun's coming up over the river, I'll thank you again for the privilege of addressing the group, and turn it back over to our moderator. And if we have any questions, I'd be happy to stay on as long as you'd like me to answer those questions.
Thank you. Thank you so much, Dr. Daniel, for that comprehensive presentation where you not only talked about the common specialty application, but you also gave us an update on what is there for a lot of patients, which we already see in the clinic on a routine basis, and how can we help those patients now with the available technology.
Well, it's my privilege, and thank you so much again for allowing me to participate in this with your group. I think what the online optometric learning series is doing is absolutely phenomenal, bringing this education to our colleagues around the world and bringing us closer together. We all have very different styles of practice across the world, but we're all committed to the health and welfare of our patients and united in that effort together. And I'm just honored and privileged to be asked to present every time here.
Thank you. Thank you so much. So the first question we have got, Dr. Daniel, is asking on probably in terms of your opinion, which what are the corneal abnormalities or irregularities which you would kind of help patients with soft lens or RGP or sclerals? Do you have a take on this and probably give us your ideas on this particular aspect?
Yeah, that's an excellent question, because no two eyes are alike. Each eye has its own unique set of circumstances, and I would just start by prefacing the remarks and saying that there are soft lens designs that, like I pointed out, that deal with keratoconus, post-refractive surgery cases that have reverse geometries, and so you can fit a large variety of those, even up to some advanced cone progressions. You're able to treat these things. But there are other underlying things you have to consider. I always consider not just the curvature values, but the shape of the eye. And a third thing I consider is where's the location of the apex of the irregularity, because that guides you a lot as to whether I'm going to do a soft or rigid lens fit. So knowing where that apex is, and also how symmetric is it across a hemichord. So if you have a highly asymmetric cornea, it may be very, very difficult to do anything with a soft lens, even a thicker one. But you'd be surprised. So many of these cases, I've had cases that have gone all the way up to 12 diopters of corneal astigmatism that have done surprisingly well in soft lenses. So each patient is a little bit different. I think if centration is a problem, then I'm going to start migrating more towards hybrids and scleral lenses. If I do corneal GPs, it'll probably be intralimbal designs because those will center better. So I'll look at those factors too. And I also think about what is the underlying pathology. If I'm dealing with a graft and that graft is 10 years old and I know my endothelial cell counts are likely pretty low, I'm going to want something with a much higher decay than I can get in a soft lens. And so I'm going to go with some of the hyper decay materials, either in an intralimbal design or possibly in a scleral design that's a low clearance sort of look. And there I may use something like a latitude lens or something that's based on scleral profilometry, where I can have a uniform tear reservoir thickness and not have shallow clearance at the apex with a big standoff at the base of the cone. So all of those things are factors to consider. And with grafts, you can certainly get reverse geometry curves and all of those designs, something that's oblate shape.
Right. So I think it's a multifactorial analysis.
It is. Yeah.
Yeah. Looking at a lot of variables in terms of the ocular health, measurements, patient's handling, and then probably you could come out with a suggestion. And I like your point that no two eyes are the same. So that's very important to take note of. Yeah. One more question is asking about your opinion in terms of corneal shield when it comes to the ulcers in terms of VKC. What type of contact lens option would you kind of suggest or prefer to fit them with?
Yeah, these are really challenging cases. As you know, if you've worked with them, they're oftentimes on steroids, and tacrolimus and is more common, I think, overseas than it is here in the U.S., but it's available. So we do have some immunomodulators that we use on these cases, and even cyclosporin and some of these things have been tried. But, I will do sometimes in their most symptomatic periods, even a amniotic membrane with bandage contact lens, and there's a variety of different ones out there. I tend to gravitate towards whatever the highest DK I can get is. So that may be something like a bioaffinity lens, maybe something like a night and day lens from Alcon. Those are two of my favorites. Lots of people use the Oasis lenses as well, and put them in and see what kind of result I can get with a amniotic membrane under there as well. And that just serves as a scaffold to help some of that epithelium regrow while you're able to still put in steroids as well. And while you do that, I mean, typically you're going to use a preservative-free antibiotic, something like Moxiza, on top of those as well, to reduce the risk of developing an ulcer, since you're going to have these on the eye, continuous wear for probably a week or more as well before it absorbs. So it just depends on how bad it's affecting the eye.
Thank you, Dr. Daniel, for spending the early Sunday morning with us, and sharing your expertise and suggestions, and giving us your views on the topic. So thank you so much for your time.
My privilege.
Yeah. Please be reminded, we do have a session coming up next week, which will be on the genetic test for keratoconus, to use them for corneal dystrophies as well as for keratoconus. So until then, take care, be safe, and I wish to see you next week. Bye-bye. Thank you. Bye. Bye, Dr. Daniel.
Bye-bye.